Well, welcome to this presentation on primary care gaps in remote Queensland, perceptions of practitioners and managers. Before we start, I'd like to begin by acknowledging the First Nations people as the traditional custodians of the lands on which we're meeting today. And also I'd like to pay my respects to elders past, present and emerging, and extend that respect to all First Nations people who may be listening today. I would also like to acknowledge my co-authors on this work, that's Keith Palanna, Christian Hughes and David Stanyer. Now, I'm not going to spend much time on this introductory slide, other than to say that Health Workforce Queensland is the rural workforce agency for the state. I've listed a few things that we do, but I've highlighted one point in red because this will provide some context as to why the work we're presenting today has been undertaken. The annual Health Workforce Needs Assessment is a reporting requirement to the department in Canberra, and one of the main differences lies in the wording of that report. It's workforce needs. Now, this compares to most community assessments that are health needs of the community. So it is looking at the same problem, but it's looking through a workforce lens. Well, what do we know already? We know that workforce planning is difficult, but it's especially so for remote areas. Things like small population sizes, isolation, attraction and retention of staff, large distances between communities, and the extra cost both to provide services and for health practitioners to actually live in those communities as well. The outcome, increasing remoteness, equates to poorer health outcomes. Now, with workforce planning, it's generally driven by population health data. Things like disease prevalence, disease incidence, Medicare billing rates, population characteristics, those sorts of things. Now, we asked ourselves, is this enough? There are other elements that may be impacting workforce needs. So there's a lot of talk currently about rural generalism, even though it's been around in the medical workforce for quite a long time in Queensland. Can rural generalist skills impact on workforce needs of the community in such a way that population health data doesn't actually tell the whole story? Adding further to issues in remote areas is the way services are delivered. So remote is very different to very remote communities. So there are very few private providers in very remote areas. Services are mainly delivered through Queensland Health and the Aboriginal Community Controlled Health Service sector. There's also a lot of recent impetus for finding place-based solutions. So what's the best way to go about this? We asked ourselves, what else could we do? What could we add to help understand community workforce needs? So let's go to the method. Now, it is important, talking about the method, that you need to understand that this isn't a research project. It's a quality assurance project to fulfill our reporting requirements to the department. So we developed, in consultation with our stakeholder group, 17 primary care workforce disciplines and 13 primary care services. Now, these ranged from general practitioner workforce, speech pathology workforce, to things like Aboriginal and Torres Strait Islander health services and palliative care services. Now, what did we do? Well, the data was collected for the annual Health Workforce Needs Assessment, so our reporting requirement to the department. We used online surveys. We emailed invitations to practitioners and managers in our database. We had a link on our website. We opened this survey in September 2022 and closed it down at the end of February 2023. We only look at remoteness areas 2 to 5, which is equivalent to modified Monash 2 to 7. We had 30 statements, one for each of those disciplines and primary care services, and they were all phrased the same way. There is a serious gap in the XX workforce in my community. We asked people to rate their level of agreement with that statement along a 101-point scale from 0 at strongly disagree to 100 strongly agree. We had 800 participants complete at least one of the questions. Our medical practitioners represented 49% of those. Geographically, there was a good spread, 41.6% from inter-regional and 6% for remote and 6% very remote. Now, let's look more closely at those remote and very remote participants. Overall, the bottom row of this table shows that combining RA4 and 5, we had 44% of participants were GPs, 30% allied health. Now, there were differences between RA4 and 5s. In RA4, we had many more allied health practitioners, whereas RA5, the very remote area, we had more nurses and midwives and less allied health practitioners. Now, let's look at the top 10 primary care gaps statewide and see how the combined remote and very remote participants compared. Now, the first column has the statewide means going from highest mean rating down to the 10th highest. The second column has the means for RA4 and 5 participants, those remote area participants. And the final column has where the remote area participants ranked each of those primary care types. As you can see, most gap rating means were in the 70s, with a few in the 80s, and there was one in the 60s. Now, mental health services were the #1 in the state, but only ranked 10th for remote area participants. Community-based rehab was 3rd in the state, but #1 in remote areas with a mean of 84. Speech pathology was 6th in the state, but 2nd ranked for remote area participants. Interestingly, of those top 10 ratings statewide, 4 were not in the top 10 for remote area participants. For instance, social work was ranked 5th for the state, but 18th by remote area participant. Now, what other primary care gap ratings made it into the top 10 for remote areas? Well, coming in ranked 3rd was dentistry. Then Aboriginal Torres Strait Islander health workers, health practitioners was ranked 6th for the remote area participants. Surprisingly, audiology came in at 7th. Now, I've said surprisingly because in the statewide ranking, it was 28th ranked out of 30. And then we see disability came in at 9th. Each of these means, though, were above 70. Now we're going to have a look at the results of the top 10 for remote area participants, RA4, and very remote participants, RA5. Now the first column has the combined remote area means going from 1st to 10th, and the next two columns have remote participants means and then the very remote participant means. Now I've used red to highlight where ranking orders were considerably different between remote and very remote participants. So dentistry was ranked 3rd in the combined column. However, it was the #1 for remote participants, but it was right out at number 12 for very remote. Similarly, audiology, which was 7th overall, but for remote area participants, it was number 2, whereas for very remote participants, it was all the way out at number 15. Another notable result was the very remote mean for community-based physical rehabilitation, which was 89. That was the highest mean we recorded, and it was 12 points higher than the remote participant means. Similarly, the very remote mean for speech pathology was 82, approximately 11 points higher than remote participants. And also having a look at disability, where there was a 7-point difference between remote and very remote. Now, let's look at the next 10. Now, it's here with the 11th to 20th ranked primary care gap means that we get the largest ranking differences. Some have higher rankings for RA4 participants, remote participants, and others the higher rankings of the very remote RA5 participants. Now, aged care is the most notable of these. It was ranked 11th overall, but for very remote RA5 participants, this was the third highest ranked primary care type with a mean of 78. Compared to 21st for remote participants in RA4 with a mean of around 63. Similarly, both alcohol and other drug services and exercise physiology were in the top 10 for very remote participants, but for remote area participants, these were ranked 19th and 23rd respectively. Now, in the opposite direction, oral health, it was ranked 3rd for RA4 remote participants, but 20th for very remote participants. And also diabetes education was ranked 14th for remote, but 24th for very remote, even though the means were actually quite similar. Now, let's have a look at the final 10. Most of these correlate pretty well across RA4 and RA5. However, for optometry and podiatry, even though the means are similar between RA4 and 5, both are much higher ranked by remote RA4 participants. So, in conclusion, I think we've shown a quick, fairly easy to administer survey has provided another tool to help us look more closely at primary care workforce needs. When we combined remote area participants from 4 and 5 together, we found that they had a different ranking pattern from the rest of the state. For instance, remote area participants had a far higher rankings for dentistry, audiology, and Aboriginal and Torres Strait Islander health workers and health practitioners. While at the same time they ranked things like social work and alcohol and other drug services far lower. But we also found substantial differences according to remoteness. Remote, those RA4 participants, ranked things like dentistry, oral health services and audiology far higher than the very remote RA5 participants. While, in contrast, those RA5 participants had higher rankings for things like aged care, alcohol and other drug services, exercise physiology, and social support services. Now, very remote practitioners and managers working in communities largely serviced by Queensland Health and the Aboriginal Community Controlled Health Sector have shown important differences in their stratification of primary care gaps compared to remote area practitioners and managers. Now, this all provides further support for place-based workforce planning. When we use this data, we provide data for the primary health networks at a hospital and health service level, and we also have requests from some of the PHN for data at statistical area level 2, which is a smaller unit of geography. Finally, investigation at individual community level could be a useful tool for workforce planners. Now, we've used these questions at a community level with some work we did for the primary care workforce plan for Gladstone, and we had about 500 residents respond, and they gave a fairly clear picture of what that community believed were the most needed workforce changes. At the bottom here, I've put some of the limitations of the study. This is all built around perception, so it's not a definitive numbered result. These findings they're limited to Queensland and they may not be generalisable to other jurisdictions. And, you know, there's further research and further supporting findings needed before these can be taken as applying across remote area. Thank you very much for your time today.